Good morning and welcome to the Alabama Public Health Training Network. Syphilis is a highly contagious disease that is spread primarily by sexual activity. Today, we will discuss the signs and symptoms of syphilis, including the treatment for the primary, secondary, and even latent and late latent stages of syphilis. Thank you this morning for joining us for our program today, Syphilis Management for the Clinicians. If you have a question about our content today that is being discussed, please call or email during our broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, evaluation, and all of those forms are available online. You will need to register for this program in order to access these materials. Continuing education credits have been approved for nurses and social workers, as well as a nurse practitioner pharmacology credit. In order to receive this credit, you must watch the entire program, complete and return the sign-in sheets and the evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year and will expire on January the 31st, 2016. Good morning. My name is Teresa Dix, and I'm a nurse educator with the Alabama Department of Public Health. And with me today, I have Ms. Agnes Obacor. She is a nurse practitioner senior with the Bureau of Communicable Diseases. And now I'd like to turn the program over to Agnes. Good morning.
Good morning. Thank you, Teresa. And thank you, everyone, for watching this broadcast today. Managing syphilis is a challenge for most clinicians. Now, today I want us to focus on some few things which are very key and important to managing syphilis. I want us to, by the end of this program, be able to list the stages of syphilis, describe the signs and symptoms of syphilis, describe or discuss the impression criteria for determining treatment and follow-up. We'll also look at clinical stages versus surveillance or DI staging. We'll explain the lab interpretation for reactive and non-reactive treponema and non-treponema test results. We'll describe the treatment for primary, secondary, early, late, latent syphilis, and contact. And we'll explain required follow-up for symptomatic, asymptomatic contact, and discordant lab results. These seem to be the most frequent areas that we have questions from clinics. Now, so let's look at the definition of syphilis. And if you have few of it for you here today, syphilis is sexually acquired infection. The etiologic agent is the treponema pallidum. The disease progresses in stages, and I believe that's what makes it difficult for most clinicians to manage. It may become chronic without treatment. How does it transmit? Transmission is sexually, maybe from man to man, man to woman, woman to man, and vertical. That is a mother directly transferring to the embryo, a fetus, or baby during pregnancy or during delivery. Now, the primary and secondary stages of syphilis are considered the most contagious stages. Looking a little bit about the treponema pallidum, it's a cockroach shape, it's motile, and it's a bacteria. It cannot be cultured in vitro, and it cannot be viewed by the normal light microscope or the scope you use for wet mount. We have to perform dark field using the dark field microscope. And that is why it's different. It needs a trained professional to view under the microscope. Let's look at the stages of syphilis. And I like the stages. It makes it easier when managing patients without looking at titers per se. Because, like I said from the beginning, managing syphilis is a challenge because of the various stages and titers and all the names that they have for it. But I want us to focus on the simple form to help us manage our patients. And we start with the primary stage, occur about 2 to 4 weeks after exposure, and it begins with a chancre. It will be present at the site of inoculation. So whatever the Treponema pallidum enters the body, that's where the chancre or a sore would develop. And as we said, it's highly infectious. Secondary syphilis occurs 2 to 8 weeks after the chancre disappears. It's also highly infectious, but bear in mind, these two stages can overlap. That means you can have a patient with primary syphilis and secondary presentation at the same time. The next stage is the latent syphilis. Latent, no signs and symptoms. So the only way you will know about this stage is when you have a positive lab result in a patient with no signs and symptoms. Latent stages can be early. That means the disease occurs within a year. Or it can be late, after a year, or maybe we don't have any indication when the disease occurred. And so we can say it's unknown duration. The next stage is neurosyphilis. Neurosyphilis can also be early neurosyphilis occurring within a year, or late neurosyphilis after a year. Now, neurosyphilis can occur at any stage of syphilis, the early neurosyphilis. It can occur during the primary, secondary, or any stage of syphilis. Tertiary syphilis is a stage that occurs after a year, between a year to 10 years or even more, it can occur. During tertiary syphilis, we can have neurosyphilis occurrence, cardiovascular involvement, and the gametous disease. Now, the last stage I'll talk about here is the serophase stage. This is a stage that after adequate treatment, your VDRL or RPR decline, but always reactive. So somebody will ask, the patient has been treated, but the VDRL, RPR is still reactive. Now, aspects of syphilis diagnosis. Before we diagnose syphilis, we have to look at 3 different areas. We cannot use one aspect of it. Looking at clinical history, physical examination, and laboratory diagnosis. Let's look at a clinical history. We need to assess history of syphilis. Has this patient had syphilis in the past? Known to contact to an early case of syphilis? Are there typical signs or symptoms of syphilis in the past 12 months? Remember, you want to know the duration so you can determine if this is early syphilis or late syphilis, especially if the patient has no signs and symptoms. Is the most recent serology test result for syphilis available for you to look at and compare? Now, what about a physical examination? We look in the oral cavity. Remember the site of inoculation and now the sexual preference of sexual intercourse could be oral. So you want to look in the oral cavity. Lymph node, that's another symptom of syphilis. Could be an inguinal, and so you want to check that. Skin of the torso. And as we look at the signs and symptoms, you understand why we need to look at the skin, palm, soles. You need to look at the genitalia, perianal area, neurologic examination, just by asking the patient any unusual headache, loss of memory, simple things that determine neurologic issues. And look at the abdomen. Now the next one is a laboratory diagnosis. We cannot use only one type of serologic test to diagnose syphilis. So we have various. Dark field. Dark field will test stat in a clinic to look at the treponema pallidum under the dark field microscope. So you look at the secretions from the lesion. Serologic tests, we have two types. The non-treponema test, VDRL, RPR, TRUST, USR. But here in Alabama, we use VDRL in our lab, and some other labs will use the RPR. Why do we do serologic tests, non-treponema serological tests? The principle is that it measures antibody directly against a cardiolipin, lecithin, cholesterol antigen. So we're looking at the antigen aspect when it comes to syphilis. It's not specific for the treponema pallidum itself. Titers from non-treponema tests usually correlate with disease activity, and results are reported quantitatively. Now, I'll say most of the time when clinicians are looking at titers, it becomes very complicated. And so I want us to focus on other aspects also when managing patients. It may be reactive for life, and as I said earlier, it's referred to the serofast stage. Why do we have to do non-treponema tests? Advantages are that it's rapid, it's inexpensive, it's easy to perform, and can be done in clinic or the office. In most of our clinics, we have RPR rotators that we can do and use. It's quantitative, used to follow response to therapy, and that is what we need to know the titers most of the time as clinicians. Not necessarily correlating to the stage, just knowing that, but if you know the titer when you start the treatment, it'll help you to understand whether your treatment is effective or not. Can be used to evaluate possible reinfection as well. The disadvantage may be insensitive in certain stages. It may be false positive reaction, or it may be false negative, as in a prozone effect. That is where the antigen titer is very, very high, and so interferes with the antigen antibody formation to read. I have on a slide here, and I hope you can see very well. Now, we are quick to say a test is false negative and may not want to do anything for that patient. But if you look at false positive, you can also see that there are other diseases involved here. And so the fact that the patient is not positive to syphilis doesn't mean they don't have any problem. If you see the last point here, there's STD other than syphilis can also react positive for FTA. So we need to think about other aspects when a patient is positive and we think it's false positive. For the treponema test, we have EIA, TPPA, FTA, ABS, and CIA. And I'll say for Alabama, we typically would do the EIA, which we start our testing from, and confirm with the TPPA. Not treponema. Serology test principle is measuring antibody directed against the T pallidum antigen. It's qualitative, therefore it's not quantified. Usually reactive for life, and titers are not used to assess treatment response. I said this earlier, in Alabama, we use an EIA to begin our syphilis testing, followed by the VDRL if it's reactive, and then the TPA to confirm the syphilis test. I have a slide there, and I hope you can see this. But this is our syphilis, the new screening algorithm from our state lab. And I put it here so I can explain how some of this can be considered when we have a test that seems to be discordant. Typically, when the EIA is negative, then we say there's no evidence of syphilis, and we do not have any problems because it will be reported as negative. When the EIA is reactive or positive, the lab will proceed to do the non-treponema test, and here we do the VDRL. The VDRL is positive, then we know we have a case, and it's easy to manage, to interpret. However, when the EIA is, with VDRL is negative, but the EIA is positive, then it's giving us a little concern, and that is where we have most of our questions from the clinic. When an EIA is reactive, but the VDRL is non-reactive or negative, it could be that this patient has previous or treated infection. Now, if we have a medical record or past history of the patient to indicate or to prove that this patient was indeed previously infected and has been treated, then we're okay. We rest our case, and we are happy with that case. On the other hand, the result could be limited. It says limited RPR sensitivity, possibly false positive screening, and we need to repeat a test. Bear in mind, in our protocol, in the clinical protocol, we have it to repeat a test, and so we want to do that to make sure that within 2 weeks to 2 to 4 weeks, the result may be converted to positive, or it may remain negative. That way, we are sure that we have done enough testing to make sure the patient is not active. What if the patient? What would we do with a negative VDRL result? The lab further proceeds to perform the TPP and non-treponema test. If the non-treponema treponema test, the lab proceeds to do a treponema test, which is FTA or TPPA, and here we do TPPA. If it's positive, there's evidence of infection. It could be possible previous infection, possible cross-reactivity. We need to consider previous treatment, latent or late syphilis. And we need to review patient history and clinical symptoms to make sure, to help us determine how to manage this patient. Now, if the treponema test is negative, in this case, then we have limited evidence of treponema pallidum infection. However, we need to consider possible previous infection, possibility of false positive screening. We need to retest within 2 to 4 weeks. And with this, we will proceed to look further into managing discordant syphilis test result.
Agnes, if someone wanted to refer back to your bulletin just for a review, they could find that bulletin where would they find that bulletin?
They will find a bulletin with the Bureau of Clinical Laboratory, and it's in our document library.
Okay.
Under lab manual.
Okay.
The laboratory manual is there. Or they can email the lab, and they can refer them to where it is if they find it difficult to find where it is.
Okay.
Or they can ask me, I can send them
one. Okay.
where to go. So if we have asymptomatic contact to early syphilis with a non-reactive EIA, then we said no further testing or clinical follow-up is required, because now we have here a treponema test which is the EIA non-reactive. The patient has no symptoms, although patient is a contact, but no symptoms. So no further testing, and we have no problem with that. Next point is we have a symptomatic patient or contact with a non-reactive EIA or VDRL. Now the patient has the symptoms, so we need to offer treatment. As early syphilis, we need to repeat tests within 2 to 4 weeks after treatment or upon return to the clinic. What if we have no history of previous adequate treatment with an EIA or TPPA reactive and a VDRL non-reactive? Now here we say we will offer treatment, because most of the time we let these patients go and we can't find them anymore. So we want to make sure that there is nothing, we are not leaving the patient untreated and not knowing what is going on. Then we will repeat this test within 2 to 4 weeks upon return to the clinic. Now if we repeat a non-treponema test, which is VDRL, and it's non-reactive, then we said no further testing or clinical follow-up is required. We've done what we're supposed to do and making sure that the patient is treated if needed and there's no possible infection in there that we are not managing. I want us to look at clinical versus surveillance DI staging here. Now what I mean here is that people are used to titers, especially when we come to surveillance. We want to see the titer. And mostly when you want to report, you report based on the titer. In clinically, when we have a patient with syphilis test that is positive, the purpose here is that we want to identify possible infection early and treat promptly to prevent spread. So whether the titer is 1:1 or 1:2 over 200 over 2,000, we are looking at the patient here and want to make sure that we are treating the patient, managing well, because a patient can have 1:1 or 1:32 or 1:64 and may be adequately treated in the past or not, or may have a clinical signs and symptoms. So our point here clinically is to make sure we are able to identify disease early and treat. And the key point is clinical manifestation. Is this patient having clinical signs and symptoms? Is the EIA reactive or non-reactive? And from the beginning, as I said, if we have a patient with clinical signs and symptoms, even if the EIA, which is a treponema test, is non-reactive, we cannot just ignore and not treat. We want to start treatment and repeat the test. What if the VDRL is not reactive and the TPPA is not reactive? If we have a patient with clinical signs and symptoms, it's a concern. Now the next point comes when there's no clinical signs and symptoms, but the patient has a reactive EIA, non-reactive VDRL, and a reactive TPPA. We still need to consider, is this patient has previous history? Has the patient ever been treated? And the point here is that if we're offering treatment to establish a base, to make sure that this patient is treated, and so when in the future, when patient comes to the clinic, we know we have proof that this patient's been managed in the past, and this lab results here is a pattern of negative as all the time, or not. So when a patient has no clinical signs and symptoms, but a treponema test is reactive, we need to rethink and make sure the patient is managed adequately so that in the future, when we have a repeat test coming back, we know exactly how to interpret and not be thinking what is going on. It will also help us to know if something changed. If there's a serological change in our testing, it helps us to manage this patient and say if it's a reinfection or it's a whole pattern of the test results. Now for surveillance, the DIS purposes is reporting to CDC and contact tracing. Now what they're looking at whether the treponema test is reactive or not reactive. Now if they're looking at a non-treponema test, they want it titrated. And that helps them to report. And so most of the time when you call a DIS on a non-treponema test that is not titrated or negative, they may say we're not following. But I want to refer back to Dr. Bowling, the director of CDC, sent a notice time back in 2011. And it was given examples what to follow and not to follow. Now you get back to her answer in referencing non-treponema tests that is not reactive. It said it will be based on the program that they're working in. So based on our history of high syphilis back in 2005, 2006, 2007, we started a rigid management procedure and follow-up. And we can see our numbers gone down based on the rigid management that we have for our clinics. And I can show here, even without them asking the question, whether the type of follow-up we have is really working in our clinics, or whether it has made an impact for Alabama.
On your slide.
In my slide here, which you don't have, because I made this slide just last minute. In 2010,
let's pull it down just a little bit, tiny bit. There we go.
Yes, in 2010, we have primary syphilis cases, 260. Now, this new algorithm started in 2011. We can see a change here going down 228. In 2012, we went down to 216. In 2013, we went 183. 2014, we are down again, and now our total number is 157.
Yay.
With our new algorithm started. You can see a steady decline in our cases. And I think it's working. It may sound rigid. It may sound that we are doing so much. But remember, we have to work with the mobility that we have and make sure that we are doing what we have to do to make sure we keep declining in syphilis and not going up. And I have congenital syphilis here, follows a pattern. You can see the same way you're declining in congenital syphilis because primary syphilis is going down and congenital syphilis will also go down with it. So we are working hard and understand that, but I want our DIS to continue to help us. If a non-treponema test is not reactive, we want to know if the patient has ever been treated, and so you are the source for us to help for us in the clinic to make sure that we understand the past history, the record that is there, to help clinical staff manage this patient well. So we proceed with a slide. Now coming to impression criteria. Primary syphilis. We already talked about the stages. Now let's look at some signs and symptoms or the impression that will help us to manage this patient. If we have a consistent clinical exam findings of genital or non-genital single or multiple painless rublet ulcers, or a lesion that is highly suspicious for syphilis chancre, or we have a dark field that is positive, we will consider this is a primary syphilis. Now, dark field, you have to be certified or be a lab tech to do that. This is a penile chancre. As you can see, it's clean base, indurated. This is a labial chancre. This is an anal, perianal chancre. Now, because syphilis chancre is painless, we need to examine patient to see, because the patient may not know they have a chancre in the perianal area. That's a tongue chancre. Remember the site of inoculation. And that's why it's very important to examine the patient. We look at the oral cavity all the way, every area that possibly a chancre could be. And that is very good when we ask the patient their sexual preferences, whether they have oral sex, anal sex. It helps to focus on your exam as well. What about secondary syphilis? That's the second stage of syphilis. It could be a generalized or localized cutaneous eruptions without explanation. Or it can be generalized lymphadenopathy. We have a palmar or plantar rash, mucous patches on the tongue, oral cavity or lips, condyloma latera, which is a moist, whitish, gray, wart-like looking. Now, this lesion is a little bit different from genital warts. If you've seen genital warts before, it's dry. Condyloma latera is moist, more fleshy looking. Alopecia, unexplained hair loss, dark field positive material from cutaneous or mucous membrane lesion. And now let's look at some of these presentations, secondary presentations. You have the skin. You can see the palmar and plantar rash.
Agnes, does that rash on the palms and the hands, does that tend to go away with time?
Yes.
As the disease progresses?
Yes.
Okay.
Yes. For early symptoms, primary and secondary syphilis chancre and all the secondary symptoms, they can go away, treated or not. Mm-hmm. So that is why it's very, very important to actually follow up with a patient. Mm-hmm. Because a patient, they look at it, and most of the time they will be waiting to go to the doctor if it gets worse. Mm-hmm. And it will be there, but it will go away. And so they think they're okay. Mm-hmm. And most of the time when you ask patients, especially when you have a lab results and you want to establish whether this a lab result without signs and symptoms, you have a positive syphilis test, no signs and symptoms. And as we said earlier, for clinical management, you want to be sure, is it early, is it late? So you want to ask the patient, did you notice any sore? And knowing what areas the sore could be, you can ask the patient specifically in your mouth, in your genital area. And last time I was in the clinic, we had a lab result. So I asked this patient if he had any signs and symptoms, because I want to be sure whether we need to treat it one time as early syphilis or 3 times. And he said, no. And I said, you didn't notice anything on your genital area or anything at all? He said, oh, yeah. About 3 weeks ago or 4 weeks ago, I had the sore on my penis, but it went away now. Mm-hmm. So I said, let me look at it. You can see the scar. Of course, it's gone by his description. He said it wasn't painful, and I was waiting to see if it got painful. And I'll see the doctor, but it never got painful, and it went away. Mm-hmm. So that's the typical explanation that you get. Rash like this will go away in the palm. This is skin, more body rash. And you can see the genital area, papular lesions. This is condyloma latera. and it's different. The look is a whole lot different from genital warts. This is what we call the nickels and dime lesions in the face. Hair loss. Now, who would know hair loss could be possibly syphilis? But I don't explain hair loss could be. Now, what about latent syphilis? This is when we don't have any signs and symptoms, but we have a positive lab result. It may occur between the primary and the secondary stage, as I was saying earlier, or between secondary relapses and after secondary stage. Again, there will be no signs and symptoms or findings consistent with primary or secondary syphilis. If you ask the patient very well, if they're good historians, they may tell you something happened. Mm-hmm. I remember very well when a man came in with a secondary stage, and I asked about a partner. And they said, oh, my wife got that rash in her hand, but they said it was cancer. So, but it went away. She was treated and went away. So you can see the stories that goes about that. So the latent syphilis could be early latent or late latent. Now, early latent, when the disease occur or infection occur within a year. You may only know that if you're able to ask the questions and the patient could tell you, or if you have a medical record that the patient has been to you before, or somehow you can have a medical record showing that the previous year's syphilis test was negative. Then you can say, now, this is infection, new infection occurred within a year. Or if it's latent, latent is more than a year. That means you still could have a medical record showing that, well, last year screening was negative, or last year the patient didn't show up. And so you have nothing to prove for the previous year, and so we can say it's more than a year. So anything we can use to prove that it's more than a year. Or patient history if they can remember. So in early latent syphilis, we have reactive syphilis, ERA, or TPPA, but we do not have a VDRL, or we have a VDRL. How can we manage this patient? We must have other factors adding to it to help us determine if this is early latent. If there's no signs and symptoms consistent with primary syphilis, plus any of this within the past 12 months, history of symptoms consistent with primary secondary syphilis, or documented serologic conversion, like I said earlier. Or you have a 4-fold increase in RPR or VDRL titer in a person who has previously received adequate treatment for syphilis. Or we have history of exposure to primary or secondary or early latent syphilis. Or we have only possible exposure has been within the past 12 months. Then we can say this is early latent syphilis. And it helps to know because of treatment. For latent syphilis, we have a laboratory findings of reactive syphilis ERA or TPPA with or without VDRL or PR, plus no signs and symptoms. That's consistent with primary or secondary syphilis, plus any of the following in greater than 12 months or greater than a year. History of symptoms consistent with primary or secondary syphilis. The patient can tell you more than a year in occurrence, or documented serologic conversion. Or we have a 4-fold rise in a RPR, VDRL, in a person who has previously received adequate treatment for syphilis infection, history of exposure to primary, secondary, or early latent syphilis, or no possible exposure within the past 12 months. If we can establish this, any of this, then we can say patient has latent syphilis. And I believe that's where the confusion comes with with clinical staff trying to manage patients with syphilis and no signs and symptoms. What about unknown duration? Again, no signs and symptoms of syphilis, no history of exposure to early syphilis, being primary, secondary, early latent syphilis, and treatment in the past, or treatment in the past. And we also have insufficient information to determine the duration of the infection or most likely time of exposure. And so we said it's unknown duration. As we said, neurosyphilis is another stage of syphilis. It's when the Treponema pallidum invades the central nervous system. And it may occur at any stage and can also be asymptomatic. Perinatal the clinical manifestation can include acute syphilitic meningitis or meningovascular syphilis or ocular involvement. Most of the time, uveitis is the most common ocular involvement that patients present with. Or it can be late neurosyphilis. And here, general paresis. And we can also have ocular involvement, tabes dorsalis as well. Now, to help this patient, we need the cerebrospinal fluid examination, CSF. And if you have patients with syphilis who demonstrate any of the following, like neurologic or ophthalmic signs or symptoms, evidence of active tertiary syphilis, like gametous lesions, we will see some pictures along the slide. We can ask for or refer patient to have CSF examination. Or if we think there's treatment failure, which means our titers are not going down fourfold after treatment, we would think this patient probably need CSF examination to help. If we have an HIV infection with a CD4 count about 350 and or a non-Treponema serological test titer that's more than 1 to 32, then we can refer this patient also for CSF fluid. And there's just a slide of how it looked, the spiral kit in the neuro tube. Tertiary syphilis or late syphilis. Approximately about 30% of untreated patients progresses to tertiary stages within 1 to 20 years. It's rare because of widespread of availability and use of antibiotic. And I'm surprised about 2 years ago, there was a case of tertiary syphilis where I think the young lady was about 39 years old. And by the time she was found, she had a really bad stage. And I was wondering, in this modern age with antibiotic widespread, that she went that long. But she was confined and to a nursing home, I believe. And before it was tested, somebody tested and found out that's what it was. So it can occur. So manifestation of tertiary stage, you have those gametous lesions and cardiovascular syphilis.
Agnes, do you have a picture of those gametous lesions? Because I'm just real curious as to what they might look like. Okay.
This is how it is.
Thank you.
And you can see how actually the tissue and muscle is.
It almost looks like a human bite, doesn't it?
Yes. Look at it.
Wow.
Ulcerative gamma. It's an active stage. And it can get a cardiovascular system. Okay. Let's look at treatment. We looked at stages of syphilis, and the reason is for clinical staff help us to manage the patient or help us how to treat. What to treat, how often, or how long. So let's look at primary syphilis. Or maybe combine early syphilis, primary, secondary, early syphilis in sex partners. How do we manage them? We're using a recommended therapy by CDC, and that's the benzathine penicillin. We have bacillin in our clinics, and it's 2.4 million units in a single dose. IM. If a patient is not pregnant, but they have true penicillin allergy, it's not the patient that is not using penicillin but because the mother said they're allergic to it, or they just don't feel good when they take it. It doesn't taste right in the past when they were babies. But we have patients with true, maybe anaphylactic, history of anaphylactic symptoms during penicillin use, severe rash. Then we will offer alternative treatment. And in this case, we're using doxycycline, 100 milligrams by mouth, twice a day for 14 days. Or we're using tetracycline, 500 milligrams, 4 times a day for 14 days. Now, if you look at the frequency in a day and the duration of taking these medicines, there's a chance that a patient may not take it. So that's why we want to be very, very sure that this patient is not having a reaction. Now, typical example, about 4 weeks ago, I believe, I was training in a clinic, and we have a patient who said she is allergic to penicillin. So I was wondering, the patient has a secondary syphilis, lesions in the palm as well. And I go with the recommended therapy, the penicillin, because that is the best. And you're sure that the patient is treated by you yourself, the clinician, and there's no doubt that you've taken care of this patient. So I said, how do you know you are allergic to penicillin? I said, my mama told me. And I said, can you put your mother on the phone? So she did. And the mother said, no, I didn't say that. You are not. It was your cousin.
Oh.
So for all these years, she's about 35 years old. She thought she had penicillin allergy. And that's what she told providers every time. She's not. And that was not my first incident of making sure that I verified penicillin allergy. There was another case also, this patient, and an HIV positive. And I wanted to be sure we have this patient taken care of. And it has a history of, my mother said I'm allergic to it. I said, can you put mom on the phone? And mom said I didn't say anything like that. So we have to be extra careful before we offer alternative treatment. We need to really verify if they have true allergy, then we will not risk the chance of giving them penicillin. But we need to really verify if they're truly allergic to it. Now we come to latent syphilis of unknown duration. We have to treat with penicillin, Byzantine penicillin G, 2.4 million unit IM for 3 weeks. That's every week for 3 weeks. And again, I re-emphasize, that is why you want to be sure that the patient is not allergic to it, because if you look at alternative treatment, we go to 28 days, almost a month of taking oral therapy. The patient may not take it because I'm a healthcare provider, but I will forget and may miss it, a dose, not deliberately refusing to take it, but forget it. So we have to inquire carefully if the patient is truly allergic or not before we use alternate therapy. What if a pregnant patient who has primary syphilis, secondary or early latent syphilis, and partners? The only recommended therapy for pregnant patient, according to CDC, is to use the Byzantine penicillin, 2.4 million unit IM in a single dose. For latent syphilis, we will use same 2.4 million unit IM every week for 3 weeks.
That's one injection per week.
Per week.
For 3 weeks in a row. Okay.
Yes. Now the penicillin comes in, the bacillin we have is 1.2 million unit. So you make sure you have 2 to make the 2.4. And they have to come every week. What if they have true allergy and they're pregnant? Now, we cannot offer the alternative medicine in this case. We have to have them desensitized and treated with penicillin in a hospital, monitored. So we have to actually make sure we understand this process and what is going on. We actually have one patient being monitored right now by UAB, and hopefully the patient will deliver soon, within maybe 4 weeks, and we know we're taking care of this patient. So it's doable, and we have to make sure we refer this patient for appropriate treatment.
Well, in this scenario, you're dealing with 2 lives
Yes.
there, so that's really important. And I guess maybe another clue there would be if the person utilizes an EpiPen or has used an EpiPen in the past. That kind of gives you a really good indicator that they may have some anaphylactic reaction things going on.
That's true. That's correct. Let's look at referral for management. You know, we run the county clinics, so we are able to manage primary, secondary, and early latent syphilis, or syphilis of unknown duration. When we have cases like pregnant patients who are allergic to penicillin, then we cannot do that in our clinics. We have to refer them out for an allergic desensitization. What we would do here, I have several calls that say we don't know what to do. As I said earlier, we have one patient that is being managed by UAB. The provider is in Montgomery, but the patient was sent to UAB because I believe they're short of reagents to be used for testing, allergy testing around Montgomery, but UAB has it. So if you have a patient in Alabama and your county or the city where you are, providers are not able to test and determine if desensitization is needed, you could refer these patients to UAB because it's currently being done in UAB. What about patients with suspected neurosyphilis, tertiary syphilis, or congenital syphilis? We want to send them out for treatment because we will not manage those in our clinics. When to offer treatment. We just talked about treatment. You have a patient, you're thinking, do I offer treatment now or wait? In symptomatic patients, regardless of the test result, you've seen a patient, you've seen signs and symptoms, you've seen a chancre or a lesion that really look like syphilis chancre. You may or may not have the opportunity to perform RPR in a clinic start. The recommendation is offer treatment, because if you believe that syphilis chancre, it is. Because by the time the lab comes back, you may or may not find this patient. So it's good to offer treatment. What about asymptomatic patients? Asymptomatic patient with a reactive treponema test, we'll say offer treatment while you repeat the test to confirm. And contacts. If a contact is symptomatic, or contact who is a contact to early syphilis, that's primary, secondary of early syphilis, we need to offer treatment. And I think I went ahead of myself on this. I think I explained this slice earlier. By history, if we have a symptomatic patient who have reactive syphilis EIA and or TPPA, with or without VDRL plus any of the following, we need to offer treatment, like history of symptoms consistent with syphilis, early syphilis, primary or secondary syphilis, history of recent exposure to a primary, secondary, or early syphilis, or reinfection, or if we suspect inadequate serologic response to past treatment. Assuming we started with a VDRS 1 to 32, we provided treatment. 6 months. If the patient is early syphilis, like primary, secondary, or early syphilis, and 6 months later, we repeat a test, and we still have 1 to 32, or let's say 1 to 16, there's no adequate serologic response. We need to see 4-fold decrease. We need to see 1 to 8 or below. And we'll be happy this patient is adequately treated. Otherwise, we need to determine the cause of the response. No history of past adequate treatment, we need to provide treatment for a symptomatic patient. If there's no test result available to compare with previous tests, we need to offer. If we have a patient here, asymptomatic, but with a reactive treponema test, nothing to compare, we need to offer treatment. And also, we have a 4-fold increase in a non-treponema test, VDRL or RPR titer, in a patient with history of past adequate treatment, we need to offer. Assume we have a patient in the past, 160 to 64, we treated, and then we had a good response. 6 months later, 1 to 16. Now this patient showed up 2 years later, 1 to 64 again. Then there's an increase, because we've seen a 1 to 16, once we're back to 1 to 64. So we need to.
Are there some things that may make that happen that you can think of?
Yes, could be reinfection.
Okay.
Yes. If we see a 4-fold increase, that's a reinfection. Because we treated the patient adequately in the past. And now the patient is back with the increase in the fold again, in the VDRL, RPR titer, possibly reinfection. We will treat contact to primary, secondary, or early syphilis regardless of the syphilis serologic test result. That's the protocol we established. What if we have a patient with verbal history, or we have a referral from DIS of a patient as a contact to primary syphilis, secondary syphilis, or early syphilis? Regardless of the lab result, syphilis test result, we wanted to start treatment. We treat contact with late present syphilis or syphilis of unknown duration if the EIA is reactive. But if it's not reactive, we will not treat, because now we have established that this patient is not. Because latent syphilis is not considered a contagious stage. So if the patient a contact to a stage, latent syphilis or unknown duration, has a non-reactive test result, then we will not treat. But if they do have a reactive test, then we will treat.
It looks like it might be a good time for us to just take a little break and give you a little break, and we'll regroup and join us back again in about 15 minutes, and we will continue on.
Thank you.
Welcome back. Agnes and I have been having a very interactive conversation about syphilis and how to treat it, how to test for it, what it looks like, and the symptoms. And we're glad you're back to join us for Part 2 of the Syphilis program for clinicians. I do want to mention that the information that we have covered in this program today is specifically designed for Alabama Department of Public Health staff, and it is a resource for our people to utilize for treatment modalities. So, without further ado, we shall turn the program back over to Miss Agnes, and we will finish up the rest of our syphilis program.
Thank you, Teresa. Thank you, everyone, for coming back. I think before we proceed, I would like to answer a question that came earlier. The question says, what is the title result of VDRL, RPR, non-treponema, coordinating to various stages of syphilis, and how to interpret the result? That's a good question. But for experience in a clinic and how to go the easy way for clinicians to understand how to use the titer in the clinics, I will probably differ a little bit, because relying on titer levels alone makes it too complicated for clinicians to provide treatment. But let me say, for primary syphilis, sometimes you may not even have titer when tested, if it's tested very early, because it's still in the lymphatic system, it's not made its way to the bloodstream yet. Doesn't mean the patient doesn't have syphilis. But anywhere from 1 to 32 and above could be primary syphilis. Now, when it comes to secondary syphilis, though, most authors and specialists or experts would say for 1 to 128 or higher indicates secondary syphilis. You can understand that's the very active stage. The treponema pallidum made its way to the bloodstream. Everything is high. That is when almost 100%. You can do your RPR, and it's 100% even when you do start in the clinic. So that's what we have high. And again, 1 to 32, we'll consider it's a recent case of syphilis. Below that will be not a recent case of syphilis. I hope this explained, but in clinical standpoint, when we're trying to manage a patient, the titers really doesn't say a whole lot to help us manage the patient. I believe it's the clinical presentations, the history, the past and present history of the patient, clinical signs and symptoms, and the lab result that we have help to manage a patient. Again, I hope this helped. Otherwise, we can discuss again. Do we have more questions so we can?
We do, but I think maybe we'll just go ahead and go on with our content if that's okay, and then we'll fill in what time we might have left with our questions.
That would be good.
So be sure we cover our content.
That's right.
Such good content.
So now let's go back and look at syphilis patient follow-up. So you realize once we provide treatment, so what we did from the beginning, we look at stages, we look at signs and symptoms and treatment. Now we're looking at follow-up. When we get a patient back, want to evaluate signs and symptoms. Weekly penicillin therapy, we want patient to come back. Confirm syphilis infection, that is if we want to repeat a test, or we want to check response to treatment. So those are the ways or areas that we want to have a patient back in a clinic so we can see them. Now the first one I want to talk about follow-up for treated primary or secondary syphilis. You have a patient, you confirm that's a primary or secondary syphilis, you provide a treatment. We want this patient back 2 weeks for clinical evaluation if we gave doxycycline or tetracycline for treatment. Why do we want to do that? Because we provided treatment for 2 weeks. Twice a day if it's doxycycline, 4 times a day. If it's tetracycline, is this patient really taking this medicine? So we want them to come back for clinical evaluation. Surgical testing, 6 months to 12 months and 12 months after treatment with penicillin therapy. If we use the alternative therapy, that's a doxycycline or tetracycline, or if this patient is HIV infected, we want to have this patient back more frequent. We want to look at a month, 3 months, 6 months, 9 months, 12 and 24 months. And I would like to say for all this serological testing, if the titer go down fourfold, there'll be no need to be bringing the patient back again because we have established adequate treatment. And the reason for following a titer serologically is to make sure that the titer go down fourfold. What about follow-up when we treat latent, that's early or late, syphilis or syphilis of unknown duration? We want to see this patient every week for 3 weeks. That is, we start the treatment, they need to come back the following week for the second dose, and the third week for the third dose. Surgical testing, 6 months, 12, and 24 months after treatment. How do we know if the patient responded adequately to our treatment? For primary and secondary syphilis, we want to see the non-treponema test, the VDR or RPR titers, 2-fold dilution or 4-fold decline within the 6 months after therapy. For latent syphilis, we want to see a decline 6 months after therapy. That's early or late latent. If it's inadequate, if to determine inadequate response, we will see a rise in the titer, fourfold or greater, after initiating the therapy. Then we can determine this patient treatment was not adequate. It could be because we use alternative treatment. It could also be that this patient is probably reinfected, or this patient may probably have neurosyphilis or something of the sort. And so that is why we want to follow up with this patient and monitor the titer after treatment. I already said this. So what do we do? How do we intervene for inadequate response to treatment? We have to refer this patient for cerebrospinal fluid exam if needed. We will retreat all stages as latent syphilis if risk for ring exposure is low and the presence of neurosyphilis has been ruled out. Let me explain this. We want to retreat this patient. We'll be treating them like latent syphilis. That means what we're doing, treating them 3 doses of 2.4 million unit bacillin once weekly. If we determine that it's not a new infection again, the patient has not been re-exposed to infection again, or we can establish that this patient may not be having neurosyphilis, then we can retreat them. But if there's any indication that this patient may have neurosyphilis based on the mental status, based on complaint, they're having ocular problems, personality change, patient confirmed maybe not walking, any sign that you can determine the patient had neurosyphilis. And for full exam, if you're in doubt, you may refer the patient to have this full exam done to be sure.
Would you say we have a fair amount of patients that migrate on to end up with neurosyphilis?
We do not have many of, hardly. I have seen one patient come to the clinic. While I was in the clinic. And I'm not saying maybe it's not happening to other staff in the clinic, but they know how to refer, so maybe it goes out before we even find out. But this patient came in because it was a nursing home patient, and the patient came in because they thought they found them having sex with somebody else, another inmate in the clinic. They want to be sure they get tested and nothing is going on. But during the exam, I realized that the patient is she is about 37, she's less than 40 years old, but having dementia and was not able to flex. She flexed the knees, was not able to extend well or easily moving the knees in order to do an exam to put on the table. So I thought, she's so young. How can she have arthritis? Because that's what she said, bad arthritis. And I said, it's not usual for a 38, less than 40 years old to have that kind of bad arthritis and have some type of dementia, and that's why she was in a nursing home. So we went ahead and did have RPR done in the clinic, and it was reactive. She has no symptoms of syphilis. We have not done any syphilis tests yet, but the RPR was reactive. And that I determined right there we may be having neurosyphilis, plus also some bone and joint involvement in this case. So we refer this patient. So if you do exam, questioning, and other things, put things together, you may find out it's there. We may be missing them because of maybe quick referral to maybe having a psychological review or stuff like that without testing for syphilis. We may miss them. But again, like I started from the beginning, with the advent of antibiotic usage and everything, we may be treating some of them without even knowing it.
That's true.
So let's look at syphilis management again before we in our conclusion. Syphilis diagnosis. How do you diagnose? It's not just by one method or aspect. We have to look at clinical manifestations. And as we look from the beginning, consider the stages. The first two stages, we said there's symptoms, signs and symptoms. That's for primary, we look at a chancre. Chancre appears at the site of inoculation. Wherever there's slight break in the tissue, maybe there's an abrasion, it may be visible, it may be invisible. Or remember, during sexual activity, there may be mucous membrane disturbance or any tissue. And so, Treponema pallidum, if it's present in a partner, whoever has it, can penetrate and enter the mucous membrane or the skin tissue and be a site for the chancre. Treponema pallidum cannot be cultured in vitro. We cannot view it under the wet mount microscope. But we do dark field using a dark field microscope. Some clinics do have some of these microscopes, some don't. And it requires certification, had to be certified. Just like we have certification before performing wet mount, have to be certified in order to perform dark field. Once you determine this is syphilis, primary syphilis, you want to treat immediately. Recommended treatment is the best, the Bacillin 2.4 million unit. IM, stat. Syphilis, chancre, when you find a chancre and you have the opportunity to perform RPR stat in your clinic, it may or may not be reactive or positive. It doesn't mean the patient doesn't have it. It probably is still in the lymphatic system and has not made its way to the bloodstream yet to pick up in your tests. But we want to get these patients treated if we can establish that indeed this is a primary syphilis. Secondary syphilis, the second stage we mentioned. Secondary syphilis appeared about 2 to 4 weeks after the primary syphilis, or it may overlap with primary syphilis. Secondary syphilis, like primary syphilis, is highly contagious. Signs and symptoms is visible. Like I always say, in primary syphilis, it's a secret stage. Probably only the patient who can find it, or maybe sometimes they don't even know they have the chancre, if in the perineal area or other areas that they may not even know. So it can remain secret to the patient. When it gets to secondary stage, it's no longer secret. It's open. It's public. Because body rash, palmar plantar rash, the condylomas in the face, condyloma ladder. And bear in mind, when you're looking at condyloma ladder, if you don't take care, you will think it's a genital wart. Genital wart is different. Like I always say, genital wart is dry. Genital warts may pick out the pigmentation of the skin tone of the patient. Condyloma doesn't. It will be different. More fleshy looking, and it seems like it's a growth, actually growing, and moist. If you put TCA on condyloma ladder, you will destroy the whole place because the acid will go straight on the skin tissue, not a wart. So bear in mind, when you look at condyloma ladder, it's a very contagious stage of syphilis. In secondary syphilis, the RPR 100% will be reactive, or the VDRL 100%. Treatment is the same as primary syphilis. 2.4 million units of Bacillin, Byzantine penicillin G, IM, once. Alternative treatment, you can use doxycycline, 100 milligrams, 2 times a day for 14 days, or tetracycline, 500 milligrams, 4 times a day for 14 days. Bear in mind, patient may not take the medicine, not because they're refusing to take it, but it's so many days, multiple in a day, several days to take medicine, 2 weeks. They may forget. Therefore, before we give any alternative medicine for syphilis, like doxycycline, tetracycline, we need to really be sure that the patient has true allergy to penicillin. I believe yesterday, I have a call. I had a call yesterday with a patient who's refusing IM injection. Patient will not take injection, period. It's not like he's allergic to it, but he will not take any form of IM therapy or injectable. So we thought about, how can we convince this patient? Well, the staff said they've done everything they could, and the patient would just refuse. What I thought, we cannot make them, we cannot force them to take the IM penicillin medicine. So what do? We have to give in to give doxycycline. But as usual, when you give alternative, there's more work to do, more follow-up, which means we have to bring this patient back in at least 2 weeks to observe whether they are taking this medicine, if they have signs and symptoms, whether it's resolving. And for serological testing, we're bringing them back in a month, 3 months, 6 months, 12 months, multiple times to make sure the titer is declining, if they have titers to begin with. We talk about latent syphilis. Latent means, syphilis means there's no signs and symptoms. And again, latent syphilis can be early, late, or unknown. Now, why do we want to know all this differentiation in latent syphilis? Again, it's because of treatment choice. If we can establish that this patient has an early latent syphilis, that means the patient was infected within a year by way of the patient being a good historian to tell us when they had symptoms, or whether there's a lab results that indicate that past year patient was negative, then we have to go to 3 with treatment. But if we can establish and have all this in place, it helps us. We get 1 treatment. And so I'm happy, patient is happy. 2 injections less. So asking questions, history, taking history is very, very important to determine how to treat when it comes to latent syphilis. For late latent syphilis, we say disease occur more than a year. And for the unknown, we just don't know when. And for those 2, more than a year or unknown, treatment would be 3 times. Every week, 2.4 million unit bacilli. And let me explain the weekly therapy here. For 1 week, we are assuming patients get in today, Wednesday. Next Wednesday, patients will come in. What if patient did not show up? In our clinic, we have a grace period of 5 days. If we can give a grace period of 5 days for patients who are not pregnant. If they're not pregnant, then we can allow extra 5 days for them to come in. Maybe it's because they don't have a ride. Maybe something happened. They couldn't take up their job. Anything could happen. After this window, we have to restart the treatment all over again. So you ask, what if we were on the 3rd dose and the patient didn't show up? Show up after that. The grace period is over. Okay, we have to start all over. Now, what if the patient is pregnant? We have to start no grace period for pregnant patient. For pregnant women, if they miss a dose for a day, we have to start all over. So it's very important for us to let them understand that this is the therapy. If you miss it, we have to restart. And the key to follow up in those patients. For neurosyphilis we talk about, tertiary syphilis, we will refer those patients. If we can establish that this is the case, we have to refer them for management, for treatment, because it will require IV therapy, longer period, and they need to go for treatment somewhere other than our clinics. Serofast stage is a stage where the patient receives adequate treatment, but the test result remains positive. It will remain positive maybe for life, and that's a serofast stage. You know this patient is being treated adequately. And that is the stage what I want us to establish, especially for the clinics that kept having patients coming back and testing EIA reactive, VDR not reactive, and TPPA reactive or not reactive. Now, in order to have peace of mind, if we initiate treatment, we have established a treatment history for this patient. And so in the future, when this patient comes in, we know the status, and we're not concerned whether to treat what was going on. Now, the next thing to look for in this patient is when the titer increase. Then we know it's something new going on. Or when they show up with signs and symptoms. Or when they get contact with early syphilis, the primary and secondary early syphilis patient. Then the whole story will change with that patient. Otherwise, we have established a treatment history for this patient, and we can use that for the future. So follow up. We are following up on patient, not for, we talk about for therapy. But what if we have a discordant lab result and we tested the patient again? What we are looking for here when we do a follow-up repeat testing for VDRL that is non-reactive from the beginning is we want it to convert. If the VDRL remain negative, you do not have to follow up anymore. Because while we're looking at VDRL helps us to determine treatment response. So there's no VDRL, there's no way to determine treatment response. So if we establish that this patient has been treated, we've done what we're supposed to do, and we'll not worry about subsequent repeat testing that comes back the same. So the VDRL is important to us clinicians to monitor treatment response by looking at the fourfold decrease, or to think about inadequate treatment if it's remained the same or increased. It is very important, therefore, that we work together, clinical and surveillance team together. Clinical staff cannot manage syphilis alone, nearly all the STDs. The surveillance staff are very, very important. DIS team is very important. We have to work as a team if we want to see Alabama syphilis go down, progressively go down, and remain down. Clinical staff will be concerned even if the VDR is not reactive and the EIA is reactive. We're not sure. We look at the algorithm. It says could be a previous treatment, previous infection, could be previously treated. But if a clinical staff has no treatment history, then they will tend to ask the DIS team questions about what do you have? And what we can help with is to provide them with information. Is there any information in the system to indicate that this patient is a previous case that's been treated adequately? Or is this patient a new case in the system altogether? This will help the clinical staff. And I believe by working hand in hand, clinical staff, surveillance team together, we can keep syphilis down. And it'll be easier for all the staff. At this time, I think we have questions that we do.
We do, and thank you very much for your area of expertise and your willingness to share your area of expertise. We appreciate you coming to be with us on the program. We do have some questions. If we've got a little bit of time that we can review those. One of the questions that we had was, does the germ or bacteria have to have an opening to get in? You mentioned there were some very specific places on the body that you may see a chancre sore from syphilis, is it very similar like HIV in that it has to have a little opening door or a gate to get in?
Yes, it's similar for all the bacteria. It will find a place to get in. And any aberrations on the mucous membrane on the skin can be a way, the gateway for this Treponema pallidum to get in.
Okay.
It may be visible or not. It may be just microscopic size, but as soon as it can get in. And aberrations can form anytime during any type of friction. The mucous membrane is having a toll on the mucous membrane and will cause aberrations. So there will always be opening. And if there's a chance, any slightest chance, it can get in. So it needs a gateway. And that would be any type of opening, aberrations, or any form on the mucous membrane.
There's one question talks a little bit about the window period that's very similar to the window period we see in the HIV patient population. Is there a window period that a person can be tested whereby that person may be positive but their lab tests are negative? And I think you spoke some about this in your presentation, Agnes.
Yes. All organism has incubation period. So within the incubation period, if you test, especially when it comes to syphilis, primary syphilis, when it's very early in the incubation period, maybe 1 to 9 days, within a week, you may not test positive.
Okay.
Because, like I said, it's in there, person has it, but it's in the lymphatic system.
Non-detectable in the blood.
Yes. So they may test negative, especially with primary syphilis. And some people may come, and I remember a case before where we have a chancre. The RP on the clinic was non-reactive. We went ahead and treated, but the patient later on the lab came back again because we do our follow-up. It was very high. So when it's not in its bloodstream, it'll be negative most of the time because incubation period, we're looking at the first 90 days for primary syphilis. So for the first few days, we may not, maybe up to 10 days, we may not have any tests positive.
Okay. The studio audience is letting us know that we have a telephone call. Caller, would you like to go ahead with your question?
Yes. This is Emily with Coffee County.
Yes.
Hi, Emily.
Hey, Miss Agnes.
Hey. What's your question?
I have a question for you because I know I emailed you a couple months ago about it.
Yes.
If we have a second false positive after they come back in and are retested, can we give the patient treatment if requested?
So what is the EIA?
EIA is positive.
Okay. What about the VDRL?
Negative.
And TPPA?
Negative.
Okay. Now, the patient has signs and symptoms?
No, they're asymptomatic.
Asymptomatic. Has they been exposed to early syphilis, primary, secondary syphilis?
Not that they're aware of.
Not that they're aware of. Okay. So what about the past lab result within a year?
Okay, they were the same as those lab results.
Last year?
Mm-hmm.
Okay. So we have a lab result that has not converted. It's the same negative. So it's a pattern, and we're not worried about this patient.
Okay. But if they request treatment, can we give it?
If they request it, you can because of the EIA.
Okay.
Now, once you treat this patient, next year, if the patient comes back with the same EIA reactive, VDR non-reactive, TPA non-reactive, you will not do anything.
Right.
Yes. But this patient is clear because last year it was non-reactive, and this year it's still non-reactive for VDR and TPPA.
Okay.
Does that answer your question, Emily?
It does, but I have another question.
Yes, Emily?
Okay, go ahead, Emily.
Because me and Miss Patricia Clark have talked a lot on the phone, and she's the DIS for my county. And I know we talked the difference about nursing follow-up and surveillance follow-up in your program.
Mm-hmm.
And if we have a false positive come back, the DIS doesn't follow up anymore. But we still have to. Is there a way that the follow-up protocols can match for both?
Okay. If you're looking at in a protocol, we don't address false positive because we're not very sure.
Right. We have to bring them back within
Yes.
the 4 weeks to
Yes.
do another test and an exam.
Yes, and a test. Not an exam, but a test. Right?
Uh-huh.
When you bring them back, because you saw them the first time, when they come back, you do repeating a test.
Yes, ma'am.
Yes. So if the test, VDR, especially VDR, remain non-reactive, then you finish your follow-up. Because
Right.
there's nothing to compare with any longer.
Okay.
Now, you talk about DIS follow-up. And I just said, in order to establish that this patient is okay and not to follow up anymore, DIS will help us to know whether this patient has a past history in their system or past treatment. So they may not follow up and report to CDC, but for our program, they need to let us know so we know how to manage this patient clinically. Is that okay?
Emily, did we lose you?
We lost her.
Sorry, Emily. We're sorry. We have another call. Emily, if that didn't address your question, give us a call back and we'll see if we can help you. Our next call is from Hale County. Hale County, you there?
Yes, I am.
Hi.
Hi. My question is similar to Emily's, although my patient has not been tested within the past year, so I don't know what her status was more than a year ago.
Oh.
Now, do we offer treatment?
So
retest? And the second part of that, do we treat a partner as well?
Can you read out your lab results for us so we can write those down and look at it?
Positive EIA.
Okay.
Negative TPPA, and negative VDRL.
Okay.
Okay. Now, when did the patient test it?
This past month, December.
Okay. Is that patient new to your clinic?
No, not new to the clinic. Just
Okay.
hasn't been tested in over a year.
Okay. Now, do you have any lab result in the file?
Yes.
What was
They're
it?
Negative.
It was negative. And so now you have a treponema test that's positive.
Yes.
What I'll do for this patient, I'll offer treatment because a treponema test is a syphilis test. I'm going to offer this treatment and then repeat a test. If the VDR come back non-reactive again, then you finish. You don't have to follow up anymore. No more. Are you still there?
Yes, I am.
Okay.
Do we treat a partner?
The partner. Yes. You call the partner and you test the partner.
Test them or treat and test.
Test the partner. When the partner comes in, you're going to have to test the partners.
So just test?
Yes. If they don't have any symptoms, you test them.
Okay.
And then you treat them based on the result.
Okay. All right. Thank you.
You're welcome. Thanks for calling. We got time, I think, for maybe one more question. Can we talk a little bit about how does syphilis affect pregnant women and their babies?
Oh, yes.
Just, maybe in 2 minutes or less. And that didn't. Go ahead, Agnes.
Yes. That's my passion because I coordinate congenital syphilis for the state.
I knew that.
And syphilis is very, I call it mean, because once a woman is infected, it will transfer to the placenta to the fetus. If untreated early, the baby will have same signs and symptoms that we saw even worse. You saw the lesions the baby will have same. Now, the problem with this is that if it's not treated, baby we have a still birth, or baby can be born with signs and symptoms. If undetected and the baby was not treated right after birth, go home, this baby will develop more problems. Now, when it comes to screening pregnant women for syphilis, we recommend that as soon as women are pregnant and go to prenatal visit, they get tested. Now, the current protocol says the women should be tested again during pregnancy if they have any risk factor. Otherwise, at delivery, they have to be tested. The law is that a baby should not leave the hospital until the mother's syphilis test is known. Now, if syphilis test is known, the baby will be tested and treated if needed. We are very, very concerned about congenital syphilis. Now, recently we had a case, and it shouldn't happen. And we're talking about treating patients to establish treatment history, observing the VDIL to make sure if it's going up, you take action. Well, this woman was tested during pregnancy. She was a known case, but during pregnancy, the titer went up, and nothing was done. Baby was born, not tested. Baby developed syphilis. Titer was 128 or 160 something, 200, over 200. Baby ended up at UAB. Get an admission and everything. It costs more. So syphilis during pregnancy has to be taken very, very seriously. What are we looking for? Early detection and prompt treatment. If we can treat the mother 30 days before delivery, that's the key thing for us. Then the baby is safe.
Okay, 30 days.
30 days before delivery. But listen, if we have a mother get syphilis during the first trimester and not tested and treated through, you see the baby will develop syphilis, stay there longer, the chances are we're going to lose that baby. So, very, very important. In pregnancy, we cannot take syphilis lightly.
Agnes, we have just about run out of time, and I know we could spend probably another 2 hours talking about syphilis. It is her passion, and she enjoys this subject matter a lot. I would like to thank you today for joining us as we have talked about the clinician's role in treatment for syphilis. Please be aware that the information that we have presented today is for Alabama Department of Public Health. Be sure and do your paperwork, your evaluations, your sign-in sheets. Take care of those things. The program will be archived in a couple of days if you have a friend that would like to watch the program. Please look forward to our upcoming programs. We have those posted on the ADPH website for you to review and plan to attend. So again, thank you for your time, your attention, and we will see you in the very near future. Thank you, Agnes.
Thank you. Thank you, everyone.